orthopedics, and especially spine orthopedics. So I did extensive study on and certifications in manipulative and manual therapy and evaluation and treatment programs for neck, back, pelvic pain, as well as extremities, but I really focused on spine. And I ended up teaming up with other leading people in the field, therapists in the field, and we were developing courses and studying patients with low back pain. This was in a spine center in Long Island, actually. And we noticed through doing these studies that a number of our low back pain patients also had incontinence. And we wondered why we were having incontinence with low back pain. So we started looking at the pelvic floor, and the best way to do that is to go to women's health seminars. So I started going to the women's health seminars, and that's where I was introduced to the fact that there are a lot of problems that women have with their pelvic floor, a multitude of problems, and they weren't being addressed. They definitely weren't mechanically being addressed. And so I felt a passion then to go ahead and take the work that we do with the spine to the women's health and combine the two and start really working with this patient population as well.
Excellent. It's quite the background. So I guess where we want to start, or the title of this event is Pelvic Health and Why It Matters. And I feel like pelvic health is pelvic floor health is a term that we hear quite a bit. Sorry, I just want to. There we go. And pelvic floor health is a term that we hear but may not understand it. So Lisa, if you could maybe talk us through what exactly pelvic floor health means.
Yeah, sure. So I think the first thing to keep in mind is that the pelvic floor is really their muscles, their skeletal muscles. And there's 3 layers of muscles that you have that constitute the pelvic floor. In addition to these muscles, you have fascia and connective tissue, and you have ligaments. And you also have, as part of the skeletal muscle of the pelvic floor, you have muscles that come from the hip and contribute into the floor of the pelvis as part of it. So the hip is an integral part of the pelvic floor. So, and all of this is at the bottom, or what we call the pelvic outlet of your pelvic girdle. And then these muscles and tissues and skin are innervated by nerves that originate in the lumbar spine primarily, and the sacral spine, or the sacral plexus. So that's how those nerves get the ability to contract, relax, and that's where you get your sensation from. So when we talk about having the health of the pelvic floor, you're talking about having health of tissue and muscles in order for them to be able to function properly. So they need to have the strength to contract. They need to be able to relax. They need to have enough sufficient strength to support the pelvic girdle and the organs. So your bladder, your uterus, your rectum, and your colon. And they need to be able to have normal sensation and function properly. So they are critical to the stability and the movement of the pelvic girdle, which is critical to all the movements that we do from our legs up and our trunk down. So all forces that come into our system get transmitted through the pelvic girdle to go to the different areas that need to provide the stability and the movement. So it's really the cornerstone of our movement and our kinetic chain.
Yeah, absolutely. It's like the centerpiece. So if there's any kind of weakness there, I mean, the rest of our bodies just don't function very well.
Right.
So I think what would help us understand, I suppose, the anatomy of our pelvic floors, you have a model there, and you're going to take us through what our pelvic floor actually, first of all, where it's located, what it's made up with, and what it looks like.
Yeah. So first thing, let me orient you to your pelvic girdle. This is your pelvic girdle. I don't think I can fit me and the pelvic girdle on the same screen, so I'm just going to focus on the model for now. Yeah. So just to give you an idea, these are your innominate bones. You have a left and a right innominate bone. So if you put your hands on top of your hips like this, you would be right on top of your innominate bones, and those are these bones right here. All right, so you have a left and a right. In the front, they articulate with each other, and this is called the pubic symphyseal articulation. So many of you are familiar with that. It's the bone right in the front of your pelvis, and that's your pubic symphysis articulation, and it's the two innominats meeting in the front. In the back, this is your sacrum, right here. It's like this little wedge, and both innominate bones communicate with the sacrum via the SI joint. So you have a left and a right sacral joint. Then the sacrum articulates with the little coccyx bone down here. So do the pelvic floor muscles. Pelvic floor muscles are red. I'll take a look at those in just a second. One thing I want to point out to you also is that this is where your hip comes in. So here's your innominate bone, and then coming down here is your hip. As I said, on this model, muscles are red. So this is some of the hip muscle coming into the pelvic floor. So if you take a look into the pelvic floor, so this would be the inlet coming from the top. Remember I said there's 3 layers of muscle. So the first layer is the superficial layer down here. The one you see in here is the 3rd layer and the deepest layer. Many of you are probably used to calling these muscles the levator ani group. And that's pretty much just a common term for the 3 layers, the groups of muscles. So as you can see, those deeper layers of muscles sling all the way from the pubic bone here, and they come back around, attached to the sacrum. The coccyx come back around to the front. They loop around your rectum, your vagina, and your urethra. They come out to the sides of the pelvic rim. So they're helping to support here. They're helping to support the SI joint, the pubic symphyseal joint. You have a left and a right pelvic floor muscle. So they join in the middle, but they are 2 specific different sides. If we look at the superficial layer, it's a much smaller group of muscles. They really close around our openings, and that's their primary function. So they close around your urethra, your vagina, and your anal, obviously to help us with our continence issues. And then underneath are the 2 deeper layers of levator ani muscles. So they form a sling type of support for the pelvic girdle and then for your organs. So it's your bladder that sits right behind your pubic bone, then your uterus behind that, and then your rectum and your colon.
So they hold up a lot of internal organs. We really depend on them so much.
Yeah, they do. They have a big function. They're also a huge part of your core support. When you talk about having core support and having stability for your lumbar spine, I mean, your poor lumbar spine is this little stick of vertebrae. That's what's coming down into here, right?
Mm-hmm.
And so what our core really does is protect our lumbar spine. And our core is just a corseting of muscles. So you have the diaphragm on top, the pelvic floor on the bottom, and then you have the abdominal muscles coming across in the front and attaching to the back muscles and fascia. And that whole drum and corset is necessary. So the pelvic floor is the floor of that drum. If you don't have a good floor, you can't have a good core. You can't have good stability.
And I guess that's kind of where I want to talk a little bit about the importance of Pilates as well, because it's so focused on our core, and our pelvic floor is such an integral part of our core. With a weak core, our pelvic floors and muscles could be weak. So with Pilates, then there's a huge focus on building strength in that area.
Yeah, a lot of my patients do really well with Pilates classes and mat work to help really connect with their pelvic floor, get it functioning properly, and then building that for functional movements that they do.
Excellent. And let's talk a bit more about signs and symptoms, okay? Because we've learned what our pelvic floor is and what it does look like. If someone comes to you with a pelvic floor dysfunction, like what does that even mean? What do they present as, or what kind of symptoms do they rock up to you with?
Yeah, it's interesting. There's a variety of symptoms that people can have when they have pelvic floor dysfunction. First and foremost, a lot of us associate any type of incontinence with pelvic floor dysfunction, which is probably pretty accurate. So if you have stress incontinence, that's when you cough or you sneeze, or maybe you jump and you lose a little bit of your urine. That would be a stress incontinence. There are people that have urge incontinence. So your bladder is a muscle as well. It's a smooth muscle. And when it contracts, that's how you empty your bladder. Um, and sometimes there's triggers that we see or things that we do, and we associate that with emptying our bladder. And so sometimes your bladder starts to preempt that, and it starts to empty when you're not ready to, or you're not in a location where it's appropriate. And that's called urge incontinence. And sometimes you have a little leaking, and sometimes people just completely lose their urine and completely empty their bladder. And then I know many of us are familiar with the term overactive bladder. And that's where a bladder, they feel like they constantly have to go to the bathroom and it can't fill. And it fills very easily, and they go to the bathroom every 10 minutes, 15 minutes, every 30 minutes. They get up several times a night. So that could be what is termed an overactive bladder. And those are all associated with pelvic floor dysfunction, as well as possibly some other urological problems. But what most of us don't recognize is that somebody that has low back pain can have pelvic floor dysfunction. SI joint pain can be a symptom of low back dysfunction. Hip, groin, or pubic symphyseal pain can be a indicator that you have pelvic floor dysfunction. Constipation. So your pelvic floor muscles need to relax in order for you to have a bowel movement. So if it's hard for you to have a bowel movement, that can be indicative of pelvic floor dysfunction. If you have pain with intercourse, if you have any alteration in sensation in your saddle region, that can be an indication for pelvic floor dysfunction. There's a variety. That's not an exhaustive list, but that's an idea, or gives you a little bit of an idea of the kind of things that you may have with pelvic floor dysfunction.
And that was a question that came in this week about pelvic girdle pain. So basically, it's an umbrella for your SI joint pain, your knee pain. It's a broad term. Would you say that's accurate enough?
Yeah, usually if somebody has when they say their pelvic girdle pain, it could be SI joint, it could be pubic symphyseal, it could be coccyx pain, it could be hip pain, groin pain. Any of those are pelvic girdle pain.
Yeah, so that's I suppose the umbrella term for a dysfunction in the mechanics. Okay, and I guess my next question following on from that is, we now know the signs and symptoms, things to look out for. So who is actually at risk of pelvic floor? Because before I met you, I would have been under the impression that, it's something that happens to women who've had children, or it's older ladies. That's kind of who I would have always associated with. But really, from a lot of your education, I have been taught that it's basically anyone, right?
Yeah, it's definitely not age dependent, although I would say primarily it has been associated with women after childbirth. And there's a lot of reasons for that. Obviously, when you're pregnant, you have increased abdomen and increased weight, and that presses down on the pelvic floor. But if you think about it, so anybody that gains weight, and it doesn't have to just be pregnancy, but anybody that has a weight gain can put more pressure on their pelvic floor and end up with pelvic floor dysfunction. Weight trainers, weight lifters, or heavy manual laborers who do a lot of that, holding that Valsalva type maneuvering and press down into their pelvis, that actually balloons out and weakens the pelvic floor, and they can end up with pelvic floor dysfunction. In fact, I don't understand this completely, but I do see a lot of t-shirts from like CrossFit people that show them lifting heavy weights and losing their urine and saying that's the way they're supposed to do it, which is completely the opposite of the way that your pelvic floor should be functioning. So it's very, very common. Anybody that has an injury, back pain, injury of the spine, injury of the hip, injury of the leg. First of all, pain can cause us to splint and guard, which causes a hypertonicity or a tightness of the pelvic floor muscles, which can alter, again, their function and their ability to support not only our organs, but our pelvic girdle. But let's say you have an ankle sprain. you end up, right, limping, not putting weight on that ankle. So you end up weight bearing on the opposite leg, which creates a lot of asymmetry in the pelvic girdle, and therefore a lot of asymmetry in all of the muscles of the pelvic girdle, not just the pelvic floor, but the hip muscles as well. But remember, I said there's a left and a right side to your pelvic floor. So one side can be tighter or overworked and the other side weakened. And once you don't have a level pelvic floor, that can cause leakage because you're not of your bladder, because you're not having a smooth floor. It's asymmetrical, and so the bladder can kind of get caught in between the two muscles, and urine can get expressed and leaked out. And that's true for males and females. And I think that's a really good point. A lot of males have pelvic floor dysfunction, so it's not just a female phenomena. Any type of abdominal surgery causes us to splint. That can be IBS patients, can be endometriosis, PCOS patients, or irritable bowel patients. Those are a number of people that usually end up with pelvic floor dysfunctions.
Yeah, and it's tough because with pelvic floor, like there's so much emotional trauma that comes with it too, right?
Yeah.
Like, and that's kind of one of the reasons why I wanted to raise awareness around this. Like, I obviously had a hip injury. That was my first kind of insight into pelvic floor dysfunction. And again, I suppose just seeing how I lost all muscle tone in my core and what the knock-on effect of that was. But so a lot of people dealing with, you know, injury, or again, as you say, they've just had a baby. The last thing we need is to sit in silence and worry about these kind of dysfunctions, you know. So I just feel it's really important that we raise more awareness and start a conversation with our girlfriends. Like, I will talk to anyone about pelvic floor issues. So I do want that to be something that everyone takes home today, is just have that conversation, because you don't want, you know, your friend sitting next to you, you know, not going to a gym workout because they're worried that they're going to leak, or they're always having to wear dark clothing in case they leak, or, you know, it really starts to affect you emotionally. And I feel like even in, you know, your relationship, if you're having a pelvic floor dysfunction that is causing sexual intercourse to be painful, that's going to inevitably have some kind of effect on your relationship. So, you know, there is help out there, and there is people that you can turn to help you with these issues. So I just wanted to make that very, very clear today, that there's always someone that, you know, that will help guide you through this.
One other point I really should make is that, so the pelvic floor is on the bottom, but the other part of the suspension of and the support for the organs is 2 layers of connective tissue that are on the top. So those are like ligaments and fascia. They're not contractile elements, but they are like suspensory ligaments. So women that have babies, and afterwards, you know, when babies come through, they can grab anything and pull anything out with them that they want to as they come through. And sometimes they do. They pull our bladder, they pull our uterus, whatever it is, and we end up with organ prolapses, where our organs are now sitting further down into our pelvic girdle, our pelvic rim. And what happens is those connective tissues have lost their integrity, and so they've become stretched. And sometimes they become stretched with weight gain, sometimes from pregnancy, sometimes with age. There's no way. So what they do with that surgery is they go in and they tighten up those tissues and they staple them to the brim of the pelvic girdle. And there's many different ways that they do that. But patients that have that surgery still really need to do pelvic floor strengthening, because if they don't, and the tissues that they've surgically repaired don't get the support from the pelvic floor muscles, guess what happens to them? They start to stretch again, and that's why people end up going back for those surgeries again. So it's really critical for any abdominal surgery, but definitely for prolapse surgeries, to go ahead and really do pelvic floor training to regain the strength of those pelvic floor muscles. And that's at any age.
Yeah, and I think that's the same of, like, you know, we've talked about this before. If you hurt your knee, or say if you had surgery on your shoulder, you have rehab to do after. So it's the exact same whenever you have your pelvic floor surgeries, is that you need to put in that work. It's not a fix. You know, you have to retrain your muscles, get them back working again. So it's along the same lines as that, really, right?
Yeah. So
one thing I used to get a little confused about this, was weak versus tight pelvic floor, because a lot of the symptoms are quite similar. Okay.
Mhm.
So how do you know if you have a weak pelvic floor versus a tight pelvic floor?
Um, Actually, it's hard for an individual to tell. That's really when you go to a therapist and they evaluate you and they do a muscle evaluation and they'll tell you if it's tight or it's weak. But some of the symptoms are very similar. So remember, they're skeletal muscles. So if I overuse them, they can become weak. If I have pain and I'm constantly tightening my pelvic floor muscles, or I have weakness someplace else and I'm using my pelvic floor muscles to override that, they can become tight. Either one of those can lead to incontinence issues. So it's hard to tell. Usually people that have a tight pelvic floor, though, will have pain with, they can have pain with just the insertion of a tampon, but definitely with intercourse with tight pelvic floor muscles, it becomes very uncomfortable and painful. Um, you could have tightness from muscle guarding, so a lot of pain syndromes. If that's the cause of your pelvic floor dysfunction, that can lead to a lot of tightness. Um, for that, any type of nerve damage. So I had a guy who he had a herniation in his lumbar spine. He was trying to avoid surgery, and it got to the point where he ended up having nerve damage, and he had nerve damage to the specific area of the nerve that innervated his pelvic floor and his saddle region. And so even after the surgery, he ended up with a real tight and hypertonic pelvic floor. Those muscles were just constantly turned on from the nerve irritation. And so we had to work to get him to be able to relax those muscles. So it is hard to know. I would say people that strain a lot with manual labor usually have weak muscles, but they could be hypertonic too. You never know how a muscle is going to respond to being overworked.
Mm-hmm. And also too, can we just talk a little bit about breathing technique, because breath work is so important when it comes to like your pelvic floor as well.
Yeah, so what a lot of people do, instead of engaging their pelvic floor and their abdominals in the correct way, they actually just bear down on their pelvic floor by taking a deep breath in and just holding it and pushing everything out and down. So as I said, it's a corset. So if you fill it with air, then it becomes like a drum. So it does provide stability, but the wrong kind, because it's pushing your pelvic floor out and it's not using the muscles. You're just using your diaphragm and holding your breath. So anytime you do core work, you should be going through a normal respiratory cycle. Anytime you do pelvic floor contractions, you should be doing a regular respiratory cycle so that you make sure that you're contracting the muscles but not holding your breath.
And I think we're all guilty of that. And when we're working out, is that you do tend to hold your breath as you're working out. So you can imagine the pressure on your pelvic floor,
Yeah.
by not breathing, and also just like bearing down on it.
Yeah, exactly. Or when you go to lift something, a lot of us like we do a Valsalva maneuver probably more often than we think.
Mm-hmm. Yeah.
With our daily activities, go to lift the laundry basket, go to
Yeah.
the chair.
Yeah, just regular daily
Yeah,
activities is right.
yeah. And over time, that causes problems.
Yeah. And what can we do as of today, right? We walk away from this webinar. What can we do to be proactive in starting to incorporate pelvic floor exercises into our routine? And what pelvic floor exercises can we do? Because I know a lot of us have heard the term Kegels, and this was kind of my where I got a little confused is, do you do Kegels when you're weak? Do you do Kegels if you're loose? Like, we all have heard of Kegels, but do we even actually know how to do a proper one? Because they can be done quite incorrectly as well.
Yeah. So first of all, unless we know how to properly contract our pelvic floor muscles, it's hard to do a Kegel correctly. Just like a lot of us go to trainers to learn how to work out, you really should get you can't just, and this is probably what happened a lot in the past, like women would just be told to do their Kegel exercises but not really know what that means, and they kind of just squeeze and hold tight and then relax, and a lot of them hold their breath. But in actuality, your pelvic floor muscles, when they contract, they actually lift up into the abdominal region in the pelvic girdle. So because of the way that they're oriented, they squeeze into the middle and they lift up like an elevator floor. So if you're sitting on your sit bones and you can feel your pelvic floor, or all of us could just kind of sit on the seat upright.
Yeah, let's try and do that now.
You want to take a breath in and then let your breath out. And then you want to squeeze your sit bones together in the middle and then lift up like an elevator floor is gently arising. And you want to build that for 5 seconds and keep building that contraction and building that contraction. And then you can slowly let that contraction go and return to its resting position. And then you want to take 2 regular breaths after that and completely relax your pelvic floor. If you don't, you can end up with hypertonic pelvic floor muscles where you're just constantly gripping. A muscle that's hypertonic or constantly gripping can't function. It can't contract or relax. It's kind of just held there. So it doesn't help us with stability or supporting the organs. So that would be that would be an example of how to contract your pelvic floor muscles. That would be a slow contraction, right? We also have to rehab them to come in quickly. So if we cough or we sneeze, we know those muscles come in quickly to provide support. So then you practice maximum contractions the same way. Squeeze into the middle, lift up, hold tight as fast and as hard as you can, and then let go. Quick and then let go. So you practice quick flicks, slow and fast twitch contractions. I think commonly what people do is they substitute muscles. They substitute their gluteal muscles. They substitute their hip muscles. They roll their pelvis anteriorly and posteriorly, as opposed to just letting the muscles lift up into the pelvic floor. So there's definitely an art that comes with learning how to do a proper pelvic floor contraction. And then what you really want to do is include that pelvic floor contraction with your transversus and your abdominal contractions. So the best stabilizers of the spine are those muscles, the transversus muscles. So if you ever walked, tried to get into a pair of pants that you couldn't quite fit into and you suck your stomach in, that's your transversus muscle. So you want to pull in with your transversus muscle and pull up with your pelvic floor at the same time. And then what happens is back muscles automatically come in to stabilize, and you get a nice core foundation upon which you can then do abdominal exercises and other exercises. Mm-hmm. So there's a really specific technique to doing a proper pelvic floor contraction.
Mm-hmm. And one thing I actually have noticed before, well, we talk about the transverse abdominis, like they're like our deep stabilizers of the core. Mm-hmm. So like aesthetically, you can look quite toned in your abdomen, right? But it doesn't necessarily mean that your core is strong. Would you agree with that?
Yeah, I would agree wholeheartedly with that. Your rectus muscle, which is your most superficial abdominal muscle, is the one that gives you that nice tone look and that like six pack.
Yeah.
Yeah. And the transversus uses that connection. So in the middle of that rectus is that sheath called the linea alba. And you have to be able to create tension across that sheath in order to have a good core and a good drum to that, which is why women that have diastasis recti sometimes have difficulty with that, because they have to learn how to create that tension across there again.
Can you just, sorry, can I stop you? Can you just explain diastasis recti just for those? Yeah, just how it looks in the separation.
Yeah, so on the front of your abdomen, your rectus runs from your rib cage down to your pubic bone, and you have a left and a right, and in the middle is that tissue called the linea alba, just connective tissue. So when you're pregnant, your muscles have to separate otherwise they tear because your belly is getting bigger. Mm-hmm. After you deliver the baby, those muscles hopefully come back together and the connective tissue goes back to its same size. Mm-hmm. But if it doesn't, what happens is you have a little bit of separation of those muscles, and that's called a diastasis recti. Mm-hmm. And it happens with patients that are overweight as well. Mm-hmm. But so even if you have a good tone rectus, it doesn't mean you have a good core support.
Yeah, and I think that's where a lot of people are kind of thinking that their core is okay because they look okay, but they actually could be very, very weak in at those stabilizers.
Yeah.
So I guess another question would be if we have a pelvic floor dysfunction, mm-hmm. what are the steps to improving it? Can we fix it ourselves? Is surgery an option? Like, how do we go about getting, I suppose, help or knowing what the next steps are in dealing with the pelvic floor dysfunction?
Luckily now it is talked about a lot more than it used to be, lucky for us. So first of all, women that have babies, a lot of times if they tell their OBGYN or their GYN that they're having pain with intercourse or they have pubic pain, the doctors will write you a prescription for a physical therapy evaluation and treatment. So that's one way, but that's not the only way. First of all, in New Jersey and New York, you don't need a prescription to go to see a physical therapist, at least for 6 weeks. So you could come and get evaluated if you have questions on how to contract your pelvic floor or how to do a Kegel exercise, and incorporate it into a core program. Or, you can go to your doctor and he can write a prescription for it as well.
Because I even feel that many women mightn't even know that physical therapy is even an option for pelvic floor issues, right?
No, I mean, it used to be that we went around and educated gynecologists, we educated urologists, we educated urogynecologists to say, hey, there is physical therapy for incontinence. There is physical therapy for pubic symphyseal separation. There's therapy for painful intercourse. But now there is way more physicians that are knowledgeable in this and will send you those doctors a lot now. We work with pain medicine specialists, people that do injections to help with nerve damage. They send us their patients to help with pelvic floor rehab. So there's a lot more information out there now than there used to be about pelvic floor.
Which is great, yeah. Thankfully. So I guess when I go to a pelvic or physical therapy appointment for a pelvic floor dysfunction, it's always nerve-wracking and it's a sensitive subject. So can you talk us through what an appointment with a physical therapist would look like and what, just to prepare ourselves on what to expect, because it's a nerve-wracking time, I guess.
Yeah, well, I mean, so the first part is that it looks just like a spinal evaluation where we look at your postures, we look at your movements. We'll do testing of your muscles, nerve testing to make sure everything's intact. We'll look at how you move as an integrated systems model, how your kinetic chain moves. So we'll do an evaluation of your lumbar spine, your pelvic girdle, your hip, your knee, look at all of that, get a thorough history, get a history of your gynecological history. And then specifically as far as a pelvic floor evaluation, physical therapists can do a certain amount with external palpation of your pelvic floor, but we also need to do, in some cases, not all cases, internal evaluations as well, which is not like your OBGYN. We are just assessing for the muscles, those 3 layers of muscles, for their tone, their extensibility, and their ability to contract.
So it's not that scary.
No, it's not.
Definitely.
Painful.
Definitely not. And I suppose having worked at our physical therapy clinic, that was my first eyesight into seeing what it's like for people coming in with pelvic floor. And what stood out to me was just the amount of different ages, males, females, like everyone walked through our door with pelvic floor dysfunction, and you could almost see the relief when you watch them coming out of that room, knowing that they weren't alone anymore, and they knew that a lot of this could be helped as well.
Yeah. And there's athletes. A lot of athletes fall. I've treated a lot of dancers that fall and have coccyx issues, and they have pelvic floor dysfunctions. A lot of athletes, young athletes, older athletes that have pelvic floor dysfunction from falls and injuries. So most people are just happy to get rid of the pain.
Yeah, no, exactly. And like with this webinar, of course, we've focused mostly on women's health, but we do hope to do one on male pelvic floor, because I feel like there still is not enough awareness about that. And like a lot of males as well, Lisa, they present with hip pain, knee pain, all those same symptoms. And also pre and postnatal, we could talk about that all day as well, which we hope to do, hopefully another webinar specifically on that also. So I guess, have we any questions anyone wants to pop into the chat there? We've covered all our main topics. I'm just going to go through a question just to give you time to write in there. I had a question during the week about C-sections versus labor births. Is there a difference in the, I suppose, will I have more pelvic floor dysfunction if I do a natural labor birth as opposed to a C-section?
Yeah, so I would say there's no perfect answer to that. It's very variable from person to person. Some people have vaginal deliveries, they don't have any tearing, they don't have any episiotomy, they rehab very well, and they don't end up with a lot of pelvic floor dysfunction, and they do great. Now, that being said, I think every woman, and in a lot of countries, every woman does get seen by a physical therapist after they deliver to make sure that they know how to manage if they have a diastasis, they know how to manage how to do pelvic floor contractions correctly so that they gain back their strength. So a lot of times you don't necessarily have to have any symptoms to have pelvic floor dysfunction. There's a lot of women that deliver their babies. They go about their daily, they start taking care of the baby, they go back to work, but they never actually address the weakness in their pelvic floor or get it evaluated. And that's years later when they end up with prolapses, bladder prolapses, or uterine prolapses, and end up with surgeries. So, number one, sometimes you don't have any symptoms even though you have this dysfunction. But people with C-sections have pelvic floor dysfunction too. First of all, that's abdominal surgery. So there's a lot of splinting, there's inflammation, there's scar tissue to deal with. It's very difficult to have a good transversus contraction. In fact, those muscles are pretty much turned off. And if you don't have a good transversus muscle contraction, it's hard for you to get a good pelvic floor contraction. In addition to that, they've gone through the 9 months plus of being pregnant with the weight gain, the changes in the pelvic girdle that have to occur in preparation for delivery, which happens way before we actually go into the delivery room. So both types are susceptible to pelvic floor dysfunction.
Mm-hmm. Another question just coming in there too about pelvic girdle pain in pregnancy. Is it enough to just start strengthening your pelvic floor? Would that be enough to prevent pelvic girdle pain? I suppose it would depend on what the pelvic girdle pain is, right?
Yeah. So generally speaking, it would have to be evaluated. Is it due to a hypermobility? Is it due to an asymmetry, a hypomobility, a strength issue? Is the baby sitting differently? Are you moving improperly? Those are all kinds of things that we look at in the evaluation.
Yeah, because again, that pelvic girdle
Yeah.
pain is a very broad term. It's not like there's one right answer for it. As we kind of discussed, it could be coming from the SI joint, the hip,
Yeah.
knee, all of the above.
Yeah.
Okay, another question came in here. Pelvic organ prolapse. Is it too late to rectify this without surgery? And if this is something they've had for years. So we're talking about possibly like an older lady here. If she was to start her pelvic floor strengthening now, would that prevent having to have prolapse surgery?
So pelvic floor strengthening has been clinically proven in research to help reduce and resolve grade 1 prolapses. So when you have an organ prolapse, they grade it grade 1, 2, or 3. So the smaller ones are grade 1s, and pelvic floor exercises are very good at helping people to manage and reduce grade 1 pelvic organ prolapses. And it's not too late to ever try to do that. That being said, if you have a grade 2 or 3, remember I said it's those connective tissues that have now lost their integrity, and they're not holding the organs up onto the pelvic brim as they used to do. So instead of surgery, what you can do is use pessaries, and you can get fitted for pessaries, and they act as those ligaments. So there are other alternatives besides surgery, and you would also do pelvic floor strengthening with that. But as far as exercise for the organ prolapse, they are very effective at controlling grade 1 prolapses.
Excellent. Another question coming in here. Is there any screening or outcome measures that you would recommend?
They have many outcome measures. They have all kinds of questionnaires that people use to tell if you've gained pelvic floor function after therapy. There's lots of them. There's incontinence ones, there's pain ones, there's well, there's a couple other ones I have. I could send them to you,
Yeah,
actually.
yeah, we can definitely pass on that information to the lady that's asking. Okay, I think that's all the questions I had coming in. Is there anyone else out there that wants to ask Lisa or I anything? Are we all good? So before we wrap it up this afternoon, I just want to thank you again for joining and for trusting Lisa and I to deliver this webinar to you this afternoon. Again, it's a subject that we're very, very passionate about. Lisa has also kindly offered a discount rate on anyone who would like, who feels that they may have a pelvic floor dysfunction or may want to get in touch. She will be offering 30-minute consultations that can be done via Zoom. So if you do want to get more information or talk more privately, she's going to give us a discount for that. And I will include that in a follow-up email to everyone who's in attendance today. Any emails or direct messages that is sent to us about this webinar or any questions are obviously all dealt with in complete confidentiality. So please feel free to come forward if there's any questions that you still feel that we haven't answered this afternoon. So Lisa, just before we switch off, where can people find you if they want to contact you directly?
I have a practice in New Jersey, and I work 1 day a week in New York City. And you can find me on the web, or I have a Facebook page and an Instagram page.
Awesome. And I can attach those handles again in the email that I'll be sending around. Jill, we have Jill who wants to ask a question. Let me just.
Oh, good.
Yeah. Oh.
You have to unmute yourself.
Yeah, it won't allow me to unmute yet.
Yeah, good.
I met Lisa many years ago as a physical therapist who I totally believe is the best one out there. And I have gone for pelvic floor physical therapy, not through Lisa, because we've become very good friends. So I felt a little uncomfortable, but I did go to someone that she trained a bit, and it does work if you continue to use it, which Lisa just suggested a new apparatus for me called an LV thing that I've been trying to use. But I just do want to say it is uncomfortable at first, but that's it. You know, then you're there to work and be strong, and she knows what she's talking about.
Thank you, Jill. That's so great of you to say that. It's great that you even, put yourself out there like that. Yeah, something I didn't mention, and I probably should have, there's all kinds of devices that can help you with pelvic floor rehab now in your home. And LV is one of those devices. Now you have to learn what you're doing. It doesn't evaluate your pelvic floor for you, but it is such a great tool to use in conjunction with therapy and after therapy, to have it to, once you learn what you do with the device, to really move through and continually monitor what your pelvic floor is doing.
Mm-hmm. Yeah, and usually that's something, I know like a lot of these things that can be bought online, but you would recommend maybe getting evaluated first before someone would purchase a device?
Yeah. I mean, first of all, you have to have a certain muscle grade. Second of all, you have to learn how to do the contraction before you can actually use the device properly. And if you're hypertonic as opposed to weak and you start using that device, you can make yourself worse.
Mm-hmm. Yeah, very important, because I know with such a sensitive subject, it's very easy to go online and try and find that fix, but it isn't always the answer. You're doing more harm than good.
Yeah.
And I have to say, as a patient of Lisa's over the years as well, she is excellent and very comfortable in going in to have any kind of conversation or treatment with Lisa. It's just been unbelievable to have worked with you for nearly 6 years. Can you believe that? We're like colleagues nearly 6 years now. So yeah, so as I say, anyone who wants to reach out to Lisa or I with any questions on anything we discussed today, please feel free. And if there's anyone that you feel would benefit from this webinar, we may do this again. I know we're trying to go between 2 different time zones, so it is a tricky time. But if there's anyone, just have a conversation with your friend, just spread the word. We just want to get information out there that there is help available and that no one, as I say, has to suffer with this by themselves. So yeah, just have them conversations. Girl power, let's start talking. So if there's no one else with any more questions, we are going to sign off for tonight. So on behalf of myself, I want to thank you very much. Lisa, I'll let you say your goodbyes and we'll call it.
Thank you guys. And please, anything pops into your head, don't hesitate to give us a shout out, because that's what we're here for.
Yeah, perfect. All right, guys. Me and Lisa will hang around for a few more minutes. If anyone wants to stay on, I'll knock off the recording.
Thanks so much.
Thank you.